Okay, so this session is providing an overview on the guidance note, the document that we're developing to help provide a methodology and guidance on these investment cases. So yeah, if we go to the contents page, we can, the purpose of this document is to help the economists in the room, the people who have the right qualifications, have the right background, they know about economics, they know about NCDs, but they aren't acquainted with the NCD case methodology. So in our introduction, we have these first three titles, which are what are investment cases, the audience and purpose, and the overall process of the investment case. I'll get onto these shortly, but let's just look at this number 2 here, which basically shows you 5 parts to the investment case. We figured out that there are 5 types of analyses that we would like to include in the investment case, and you'll notice that we've been through a couple of these today. We have the economic burden analysis, we then have a costing analysis, then a health and economic benefits analysis, the return on investment analysis compares the costs against the health impacts, and these 4 are essentially the quantitative exercises which will be carried out by the economists. And then we also have this institutional and context analysis, which we don't go into great depth in this document as we already have a guidance note for this. So maybe we can turn the page and look at the introduction to begin with. I think I'll skim through the introduction so we can start talking about the technical aspects. We have what are NCD investment cases. I hope by now we're starting to get an idea of what these are exactly. Then the following section gives an overview of the process of an investment case. And here, Dudley sort of touched on the process earlier in his presentation. And here we've tried to give an outline. So I can skim through this fairly quickly, just to make sure we're on page 9. So the initial step in the investment case is receiving a request from the country. As soon as we receive a request, providing that there are funds available and people trained and we have the time, we'll accept the mission and start developing a set of terms of reference so that we can sort of negotiate what we want the outcomes of the investment case to be. Having done this, we can then start collecting the data, which may be done by the economists, but it's most likely to be done by the people, the country team, the UN country team, the people who are already situated in the country, so they can start collecting the data before we go on the country mission. With the data collected, we can begin the economic modelling. I cannot stress how important it is that we start the economic modelling before the country mission that comes next, because the country mission would really want to be able to finalise the model and come to an agreement with the ministry officials on the types of results, be assured of the assumptions that we're using, and just so that we can sort of shake hands at this point and be like, great, the models are done. And then when we come away from the mission, we can then just write up the report within the subsequent weeks. And with the report written, we can hand this over to them, they will review it, and following their review at a point in the future, there will be a follow-up mission which may be carried out by the same team who went on the country mission. Then again, it may be other individuals. So this is a version of the process we're looking at. I'm sure we can go through this in more detail and get an exact outline of the process. So on that note, let's move to the the next section, section 2, which is developing an investment case. And this section is really the core section of the document, where we want to try and provide as much relevant knowledge and what we've done so far. There's basically pulled all the work we've done so far, all the resources that we've used, the sort of methodology that we've that between us we've found that's worked best, and incorporate this into this section. So the section, as we said before, is divided into each of the analyses. The first one being the economic burden analysis. So here what I've done is basically sort of summarize what the economic burden analysis is. You see that we've described it as a cost of illness study, which is what we're doing essentially. And in this analysis, we look at direct costs and indirect costs. And I've outlined the types of costs that we look at. We don't cover all of the costs that we could do, which is why I've sort of stated which ones that we are our primary focus. So, for example, for direct costs, we focus on cost of the health system rather than non-health costs, which also exist as direct costs, which could be cost of transportation. So after outlining what the burden analysis involves, we then give some idea of how you can go about doing it. So that brings us to the calculating of the direct costs. So I've explained that there are two different approaches to calculating the direct cost. There's a bottom-up approach, which would require collecting a lot of data from healthcare facilities, which is probably, I'm not sure how feasible this approach is. We haven't tried it yet, but it's certainly one way, possible way. And the other way is to use national health accounts data from the country. And this is what we have been doing so far. One issue with this is not many low to middle income countries actually store data in their national health accounts on NCDs. They won't, for example, know how much the health system spends to cure cardiovascular disease or diabetes. They might have a more aggregate figure for NCDs in total, or the data may not be amazing. So we have relied on one study. We're on page 12 by the way. So this is one study that we've used in a couple of our investment cases, which gives the average spending on NCDs across 12, 13 countries. And we've applied this average, or used this data as a proxy for several of the countries that we've done investment cases in. So I've included this as this, you may be using this data also. So that was calculating the direct costs. Another component is to calculate the indirect costs, which is looking at the productivity losses of the workforce. So I've essentially highlighted the different methods here. So we do a couple of things in calculating indirect costs. We look at calculating absenteeism, which is working out what the loss to the economy is as a result of workers missing days of work. We also look at presenteeism, looking at what the losses are for people who attend their work but work at a reduced capacity because of their illness. As well as this, we look at the losses due to premature mortality, and in the box here I've listed the different methods that can be applied in order to achieve this. And as you'll see, there are a lot of comments here, as I'm sure this point will be up for discussion. In the investment cases so far, we have used the human capital method quite frequently. This tends to produce the largest value of costs, whereas the friction cost approach generates a much smaller estimate. And the willingness to pay method is a method we could apply but hasn't yet been used in investment cases. So if we turn over to page 13, so as I just mentioned, accounting the costs of presenteeism and absenteeism for the economic burden can be, basically there are a few studies that have actually analysed the impact that NCDs have on the productivity of the workforce. So we have referenced a few documents here that are studies from the United States that have provided evidence on this relationship, and we have used statistics from these studies as proxies in our analyses, and provided, due to the fact there isn't much evidence, we're using the best evidence we can. So yeah, I've highlighted these papers, and if people are able to supplement what we already have, that would be a step forward. And I've highlighted some steps, as you'll see in bold writing, and the steps 1, 2, 3, 4, and the following step on the next page. Gives you, I don't know how many of you have done burden analyses. I imagine a couple. We have some health economists in the room. So I don't want to bore you, but the general steps in looking at the indirect costs of a cost of illness study is to start by estimating what how many people in the population have NCDs. And then after doing that, you look at a subsample of the population, which is the workforce. And because these are the people, when we're dealing with investment cases, these are the people that we are most concerned about, because they're the people that are contributing to economic output. Once we've used epidemiological data and demographic data and know how many members of the workforce have NCDs, we can look at how many productive hours are being lost during a year from these guys being ill. And then, as Jeremy mentioned, we have our P's and our Q's here, which will be used to generate the overall burden of NCDs by knowing how many unproductive hours are being worked within the year, and knowing how much loss is attached to one unproductive hour. We can get an aggregate value for the economic loss to the economy. And so page 14 now. There would also be a further step to this, which would involve being able to calculate not only what the loss is, for instance, for a disease like cardiovascular disease or diabetes. We could go one step further and look at how much tobacco or alcohol or a high salt intake in the population would, how much that costs. And this uses risk ratios and population attributable fractions, which I'm sure most of you have heard of before. So that's the burden analysis. I think we'll move on to the costing analysis, which is the second analysis, unless anyone has any questions or anything. I'm happy to move on. Okay, so the costing analysis. Again, I've laid out a set of steps that you can follow here. There are page 14 at the bottom. There are 4 steps. So there are we have the One Health tool and the WHO costing tool, which we use to analyze both the costs and the impacts of a set of interventions. And so we have a set number of interventions. We have interventions such as tobacco policies, alcohol policies, policies to reduce salt intake, and these are available within our economic models. So what we want to do, knowing that we can apply these interventions in our analysis, we first need to do the situation analysis of the country, so we can actually find out for these economic models, for these interventions that are in our economic models, what actual level of implementation the country has of these interventions. and to find out whether the country actually has the capacity to implement new interventions or scale up their current interventions. So this is basically a sort of scanning the landscape, finding out whether it's actually a good idea to evaluate the costs of certain interventions. I've then written a review of intervention delivery practices, because the interventions that we are looking at in our models, although they have the same names, like a tobacco ban, may be completely different from a tobacco ban in one country. It may mean a different thing to a tobacco ban in another country, as they may go by completely different standards. So we need to be assured that they are comparable, the interventions in the country and the interventions that we are modeling. Knowing these things, we can proceed by collecting data on epidemiology, economic data on the interventions, and then finally we can actually use our economic models to cost the interventions. So that was sort of an overview of this whole costing section, which is quite long. So maybe if we just, let's turn to page 15. Here I've just outlined the sources for the interventions that we find in our economic models. They are the tobacco empire interventions, the shake package for salt reduction, the global action plan. Interventions have been taken from these studies, surveys, and due to their cost effectiveness, we have them set up within our model and we are able to use them in the analysis. And then at the bottom of this page is box 2, where we start to introduce the One Health tool, which we'll be using tomorrow, later today, as this is the sort of central model to the analysis. On to page 16. So here we look at the current epidemiology and demography. This is the data that is at our fingertips for modeling costs. We have demographic data from the 2015 revision of World Population Prospects. We have epidemiological data within the Global Burden of Disease study. These two are set up within the One Health tool. So when you open the One Health tool, you already know population demographic figures. And then there is a third data type, which is the risk factor data, which can be acquired from the STEP survey. Below we have the potential interventions for the MCD investment cases. So let's turn to 17 to talk about these potential interventions. So there are 3 types of interventions that we can model in the One Health tool that we can look at the costs of and the impacts. We have policy interventions. We also have primary and secondary prevention interventions. These are focused on cardiovascular disease. There are primary care interventions such as drug therapy to prevent people from getting cardiovascular disease in the first place. And we also have a range of treatment interventions which span across all types of NCDs. This will make more sense when we come to using the One Health tool, but these are the categories of interventions that we're dealing with. And then, as you'll see, a couple of things highlighted. Below these bullet points, there are 2 words highlighted. One says coverage and intensity. These are the crucial data points that we get a hold of. Because what we're doing, we're scaling up the implementation of interventions. And in doing this, we need to work out what the costs will be, And coverage relates to how many people we're reaching with clinical interventions. So if we're increasing the number of people that are getting a certain type of drug treatment, we use this coverage parameter. So we need to be able to get data on this. And it hasn't always been easy to get data on this, but it may require a lot of discussions, because countries don't often hold this data point. Similarly, for intensity is used for policy interventions. The Global Tobacco Epidemic Report shows a good example of different levels of intensity for the tobacco policy interventions, and this can be sort of used as a guideline to looking at how policy interventions for salt and alcohol could be derived. And that brings us to actually carrying out the costing analysis. So if we turn to page 18, you'll see that there are two headings on this page. There's the clinical intervention costing and the policy intervention costing. They're split in two because we have to apply different models and different methods to costing these two types of interventions. For clinical interventions, we cost them using, or we commonly use the One Health tool to cost them. And you'll see there are two phrases in bold here: drug and supply costs and related health system costs. And typically we use these two categories to define or to work out the total costs of a clinical intervention. Clinical interventions are typically concerned with costs incurred by the health system, whereas when we look at policy interventions, these interventions are concerned with public administration rather than the health system. So the costs incurred for policies are more like program management teams and media campaigns, things at the level of policy. So that's the reason why we need a different method and a different model to cost this different type of interventions. So you'll see it written here for the policy interventions. We use a tool called the NCD costing tool, and there's a reference here that shows an application of this model in a multi-country case study. Gives you a good overview of the tool, elaborates on its methods, and if you're going to use this tool, which I do recommend, I definitely recommend reading this study. There are other studies available which are referenced in this document, which show you where the data sources are for this NCD costing tool. Because the costing tool comes with a default database for a range of countries, and if you would like to see where this data comes from and whether it applies to the investment case you're doing, you can take a look at how this database was generated to start with. And if we turn to page 19 now, we can. So here are basically given 3 example scenarios that you could measure for a country. They are just examples, really. So if you're scaling up a set of interventions, you may want to have a really realistic set of results, something that the country would definitely be able to implement. So you might be quite reserved in your sort of scale-up tactics. On the other hand, if the country really wants a really good advocacy piece and is less concerned about having results that are without a doubt attainable, they might want to shoot the scale up of interventions right to the top and get some really good results. And one idea might be to present multiple different scenarios, like these ones I've suggested here, and then they can see what applies to them, what they're most interested in. So that's the costing for you. And so we've done the burden analysis and a costing analysis. So the subsequent analysis now is the impact analysis of the interventions. And there are really two parts to the impact analysis. First, measuring the health impacts, and then working out what the economic benefits are of these health impacts. So the health impacts will be estimated using the One Health tool. The way we measure health impacts is, the type of health impact we measure is an incremental health impact. What we do is we estimate two scenarios. The first one is a status quo scenario where we configure our model with the interventions relating to what the actual current level of implementation is in the country that you're looking at. And then as we project our model into the future, we keep the level of interventions at their current state. So this is the first scenario. The second scenario is the scale-up scenario, where we take the set of interventions that we're interested in and we increase the implementation up by whatever they think is achievable, whatever they're wanting to attain. And when we have these two scenarios, we compare them, and knowing the difference between them is our incremental health impact. So by doing this, instead of, for example, a generalized cost-effective analysis, it's realistic in some sense that rather than comparing against the baseline where there's no interventions, we're comparing against what's going on in the country already. So yeah, it's realistic. Over the page, I think we can turn all the way over to page 22 now. And I've basically just listed several things here that one would need to bear in mind when calculating the economic benefits from the health impacts. For example, in the model, when you avert a mortality, say in the second year of your analysis, you save so many lives. Now that you've saved those lives, you probably need to work out, well, how long are these people going to be working for now that they have avoided death? Also, how long are these people going to live for? As someone rightly commented here, many of these points do relate to the burden analysis as well. So we can look at jostling the guidance note around a bit, but they all relate to this impact analysis. So with our economic benefits and our costs generated, we can then look at going forward and generating some cost-benefit ratios. So that brings us on to page 23 on the return on investment analysis. Typically, when we look at evaluating our cost-benefit ratios, there are two ways that we like to do it, or two things that we want to bear in mind. We want to be able to compare the cost-benefit ratios between interventions or sets of interventions. So you might be comparing how good a return on investment is between tobacco policies and clinical interventions. And we also like to look at two different time periods. What we normally find is that as you proceed into the future, that the cost-benefit ratio increases in size, particularly for policy interventions. So we normally have a short strategic period of 5 years, and then a longer period up till the end of the Sustainable Development Goals, 2030. So I think that's all I'll say for now. We have the institutional context analysis next, and this has been kept quite short and sweet, as we have a guidance note specifically for NCDs. So yeah, I think I'll end it there for now.